which has been very active in pediatric neurosurgery as well as neurosurgery on the whole, and is also active in the AMA, being a neurosurgical representative there, and has now set her sights on ACGME. So wanting to remain involved in education and training for those to come after her. So I'm very excited to have her here today and to hear about her transitional care of neurosurgical patients.
Thanks for the introduction. I will say it was nice to be invited back, and I think I had the pleasure of training with Dr. Sweetman when she was here, and so being able to come back for a named lecture in her honor is actually a very special opportunity for me. So I want to thank everybody here for the invitation and for the opportunity, and I hope that I live up to the name for the lecture. So I wanted to talk about something that is, I think, really important to all of us, and that's what do we do as we're getting so good at taking care of our patients and transitioning them into adulthood. And I think that the interesting thing about this topic is we don't have a blueprint. We have lots of great ideas about how to do this, but it's so specific to the geography and the opportunities that are at each individual system. And so really taking the deep dive to think about how we do this better becomes so incredibly important to our patients. There we go. So despite being at this for a decade, I still have not managed to amass any disclosures. So kind of what I wanted to talk about again is just looking at the need for transition of these patients and why do we need to think about transitioning them. Really start thinking about, as we transition them, what changes about their risk of morbidity and mortality, and then what are some of the resources that we have. I am a neurosurgeon, so I will be focusing on kind of two of the sort of bigger, more global things that we have, which are spina bifida and hydrocephalus. So a little bit about the scope of the problem, like how much do we really need to think about this? Well, when you think of the realm of spina bifida, 85% of these patients now are surviving into adulthood. We are really good at what we do. We are really good at giving these patients a good quality of life and optimizing their quality of life, getting them into adulthood. And they're going to continue to require interventions. This could be shunts, this could be tethered cords, this could be management of their Chiari malformation, this could be any of the other orthopedic or urologic stuff that they require. And when you look at all of the shunt surgeries that are done on patients with spina bifida, half of the shunt surgeries are done on adult patients in this entire patient population. And 1/3 of the tethered cord and Chiari surgeries are done on adults. So this is well beyond after we've gotten them out of their pediatric years. And then when you think about the cause of death in adults in these patients, about 90% of deaths occur in shunted patients. About half of those deaths occur in adulthood. This could be from neurologic causes, pulmonary causes, infectious causes from chronic kidney infections, bladder infections, pressure ulcers, you name it. Well, what about hydrocephalus? We're talking about 5,000 to 6,000 patients every year that transition from pediatric to adult care. And over 50% of the patients that transition above the age of 17 have had multiple revisions already at that time. When you look at a series of patients, they had actually looked only following them up to age 25, 20%, 1 in 5 patients had a shunt revision over the age of 20. So it is not an uncommon occurrence that these are people that need ongoing surgical needs and ongoing monitoring. So this is just, two of the many diagnoses. We're getting much better. Patients with cerebral palsy, patients with neuro-oncology, that is a whole different ballgame because now we're talking about all of the downstream effects of chemotherapy and radiation going into this adult population, secondary tumors, congenital heart defects, cystic fibrosis, genetic and metabolic disorders. All of these are surviving longer into adulthood. And when it comes down to it, so many of these are childhood disorders that we need to make sure that our adult colleagues are equipped to take on these patient populations. So why? Why do we have to transition them at all? I think there are some people that say, well, we're the best at taking care of this, so why should we move them on. Well, the reality is our health system is not equipped to keep these patients in the pediatric hospitals. So if you look at the actual definition of a children's hospitals, HRSA, which is the Health Resources and Services Administration, so like kind of government definition, is a children's hospital is a hospital that predominantly takes care of patients that are 18 years or younger, not even up to 21, 18 years or younger. And why that becomes important is because when you start to get beyond this threshold of these older patients, it impacts your actual status as a children's hospital and subsequently some of the federal funding and grant funding and other eligibility criteria for the additional funding that children's hospitals are so incredibly dependent upon. So it starts to become an issue. That and, you know, our children's hospitals, we're kind of built differently. We focus on the patient and their family. We're taught to think about different developmental stages. We're taught about, you know, we have different availability of services and technologies. You think about some of the lower radiation technology that we have, the EOS machines for scoliosis, having available sedation unit for scans, child life support. We just have different resources that we need to make available for our patients to be able to provide that wraparound care. But the problem is we don't have as many beds. In a decade, from 2008 to 2018, the inpatient units, pediatric inpatient units decreased by almost 20% across the country. Pediatric inpatient beds decreased by about 12%. And interestingly enough, what that is actually translating into is a shift to children's hospitals. Because what's happening is these inpatient units at hospitals that are not children's hospitals just don't have the ability to support the staff that's necessary to run an appropriate children's hospital or children's unit. So at children's hospitals, the beds increased by 12%. But at integrated hospitals, beds decreased by 18%. So not only does that mean that we don't have as many beds available, but the beds in the types of environments where that transition to adult care would be much more natural and seamless are going down. And now care is being relegated into pediatric hospitals where you don't have that natural transition or that natural partnership with our adult colleagues. And then when you look at what's actually admitted to children's hospitals, again, with that definition of 18 or older as an adult population, anywhere from 2 to 10% of pediatric hospital discharges are actually adult patients. So if we're talking about getting so much better at taking care of these kids, we need to be able to move them onto these adult hospital systems, or we're not going to have the bed capacity to take care of the children that need our care. So it's a much more global problem than just getting these individual patients. It's about kind of maintaining the ability of our hospital system as a whole to take care of all the patients that we need. And then there's the impact on ancillary staff. So beyond even that, you have nurses that are predominantly used to taking care of pediatric populations. I don't know, when's the last time anybody in this room took care of somebody with like coronary artery disease, had to deal with cardiac stent? I don't even know half of the anticoagulants that exist now because that is not even part of my armory. I just throw factor 7 at everybody. So, you know, when you start thinking about patients that are getting older, they start to get adult healthcare problems that we just don't get used to taking care of. There are licensure issues. If you have nurse practitioners, pediatric nurse practitioners in every state are going to be governed by their licensing board as far as what age of patient they're actually credentialed to take care of. So there are credentialing and licensure issues for that. And then when you think about it, we actually got a real good glimpse into this in the COVID population when children's hospitals had to become open for adult patients. And when they surveyed nurses that were at predominantly children's hospitals that took care of children's patients, over half of them said that they felt uncomfortable taking care of adult patients. So it's a comfort level for our staff as well. So how are we doing, right? We're talking about this, I think in pediatric neurosurgery, we talk about this all the time. It is at every single one of our meetings. We have panels on transition. So they sent a survey 2020, 5 years ago. They sent a survey out to all the ASPN is all board certified pediatric neurosurgeons across the country. There's six questions. Do you have a transition policy? Is it shared? Do you maintain registries to track patients as they're transitioning? Are you using standard tools in this process? Is this incorporated routinely into your visits? Do you send something to the adult team to make sure that they are ready to take on these patients? And do you confirm that that transfer has taken place, right? This is logic on a single slide of all of the things that you think should happen. So they sent the survey out. Red is not good. Green is good. So this is pediatric neurosurgeons who talk about this at every single meeting that we go to. And what does this translate into? We are doing a really, really bad job at this, and we know how important it is. So they came up with a bunch of recommendations. And some of this is really important to think this into context. The first thing that you have to do is you have to look at your own practice. And you have to figure out within your own practice and within the constraints of your local systems, how can this work? And that's part of the reason why we're so bad at this. You're a standalone pediatric hospital. Where is the natural transfer going to go? Does it go to more local community hospitals so that people are no longer forced to drive all the way downtown? Does it go to a hospital down the street? Does it go to somebody else altogether? My children's hospital is integrated into a very large adult hospital system, but neurosurgery is still centralized. And because I flank in privileges in both, certain things I will continue to monitor, certain things I need to transition to my partner. So all of this has to be very regionalized. They recommended that everybody should have a written transition policy. How are you going to do this? And that needs to be shared with patients. You need to develop a practice-specific model to monitor this and figure out how this is going to continue to occur time over time. You need to engage primary teams, your PCPs, and the onus really is on us in making sure that we help these patients find an adult provider. So we're going to go over kind of lots of backgrounds, general principles, a bunch of resources that are available that, truth be told, despite me actually feeling very passionate about this, I didn't have a lot of this information at my disposal until I started giving this talk. Let's take it back to the patient perspective. How do we think about that? How are they feeling about this? Well, it turns out they aren't really excited about this either. You know, they've known us, they followed us forever, they've spent the same, 18 to 21 years knowing and getting to know all of their care team. And all of a sudden that's going to change. And everything changes at once at the same time where they all of a sudden, these patients are signing their own consents or having to make their own healthcare decisions. And they don't know that. They're not ready for that. They're not ready to move on to a different team. They're worried about the new relationships. So there are a lot of overarching themes. They want to achieve independence in their own healthcare management, but they have a lot of concerns. How is the communication going to work when I meet new people? Are they going to be able to talk to me in the same way? Are they going to know how to explain things in ways that I understand? Are they going to be able to think about it in patients that have different developmental ages? What happens to the environment? What's it like being in an adult hospital? Am I going to still have puppies that come visit me when I'm over there? Like, where are the pet pals? We actually have, Rainbow has a pet pal fish that they have an aquarium that they push around. His name is Sprinkles. He has a little baseball card. So like, there are no fish in the adult hospital. They get Sprinkles walking around saying hi to everybody. And there's a general fear of uncertainty. They don't know what it's going to be or how it's going to be. So there are some kind of general components, like how do you make this transition process as smooth as possible? The number one absolute component of a good transition is that it has to occur in a time of wellness. In the middle of a shunt malfunction, not the time to facilitate this. In the middle of a crisis during a hospitalization, that is the worst time, both physically, medically, psychologically for these patients. So working on this type of transition really needs to be able to prepare them during times of wellness for this. So if they do present in a crisis, if they present in the time of a crisis, that it's not the first time that they've realized that they're going to be taken care of by a different team. So this should actually be a process occurring over several years. So the American Academy of Pediatrics actually recommends starting to have these conversations with age 14, not 18, not 17, at age 14 should be when these conversations start. It should be very individualized to the patient. You need to consider the local resources, what your practice setup is, where that transition is going to take place. And then it really relies on those partnerships that we need to form to make sure that we have somebody on the receiving end. So what does this include? It includes them actually understanding what is their health condition. What are the things that they should be looking out for? What are the things that they need to worry about? It includes making sure that they get over time an increase in the autonomy in their decision making, making sure that we're talking to the families. I think I had an 11 or 12-year-old patient that was exceptionally mature. And when they were in clinic with me and I was talking to them about their headaches because they had a Chiari and we were talking about it and I was several opinions down the road, I asked them, all the answers that they were giving, I could see in the corner of my eye just the look of shock on the parent's face. And I was like, what has he told everybody else that you guys have seen? Because this seems to be news to you. And they were like, you're the first person that talked to him. It's like a totally normal functioning 12-year-old patient who has no reason that you can't ask them questions directly. And even that kind of that deference to the parents, we need to start pulling that back. And then we need to make sure that they have some degree of personal responsibility, that they understand that as they transition into the adult world, there's not going to be somebody that's keeping track of things for them. That is going to ultimately transition to them. And then making sure that we actually get all the relevant information. In the world of EMR, this is a lot easier now, but I don't know when the last time one of you actually read like a very good useful note in Epic that wasn't 75% copy forwarded. We have to be cognizant of that. And that's why some of these resources really are templates to make sure that all of the relevant information gets moved forward. So where do they land? This is a big problem, right? I'll ask, I know in the neurosurgery world, if I'm like, hey, would you like to inherit my patient that's had 73 shunt revisions by the time they're 18? Everybody just looks at me and I get deer in headlights. How is it in neurology? I can't imagine that there are adult neurologists that are just sitting there with open doors and not a little bit concerned about their ability to take on this stuff. Because it's not just a matter of making sure that they're willing, but also that they have the knowledge base and the understanding to be able to manage these pediatric level problems in the adult patients. So when you think about it, there's actually a lot of fields that could work. Because most of these patients, by the time they transition, if they have somebody who's kind of overarching, managing their global care, then finding the specialists to do little bits and pieces and not take on that level of central management that oftentimes we find ourselves doing in peds really helps that transition process. So this could be med peds. There's an entire generation of our learners that are going into med peds specifically because they want to move into this realm of patients that are transitioning into adult care, looking at that kind of really complex pediatric to adult transition. This is happening all over the place with congenital heart defects, where they're actually med peds are actually doing fellowships in congenital heart defects in the adult population so that they are prepared to manage these patients as adults. I've actually partnered with a med peds physician at my hospital who had 2 of his graduates that set up practices locally that are very interested in taking on these kind of complex patient populations. And that's their niche, and that's really what they're building at. And they're amazingly capable of being able to do that because of the nature of their training. Physiatry is really helpful in a lot of these, especially in the spina bifida population, when you're talking about kind of just moving and managing all of those things that are trying to optimize their function. A lot of these can end up in with our nurse practitioner colleagues, presuming that they're in that flanking either an FMP or adult acute care opportunity so that they can see those adult patients. Because again, you're talking about primarily looking at kind of that overarching, let's see everything, let's manage the care, and let's outsource to our specialists as we need to. Primary care with the capacity, but we also know that all of our primary care providers are beyond slammed with their own patient panels, and sometimes don't have the freedom in their practices to really be able to spend the time for this. And then you look at kind of the specialty care for spina bifida. That's neurosurgery, neurology, urology, GI, orthopedics. Everything runs the gamut. So there's several different resources when we think about it, and how do we think about this transition? This is kind of a nice little map that I like. It's from the Gut Transition website. And it really talks about, like, you know, when do you start doing this and what do you start doing at each one of these visits? So when you're talking about, you know, starting even in that like age 12 to 14, talking about the transition policy, hey, just wanted to, you know, make sure this is what our goals are going to be for the next several years as you come in. We're going to talk about how we transition you. Then we're going to look and see like how you're doing in each of these components of transition. And not only are you talking about it, but you're also giving them little homework assignments to go home and say, okay, well, the next time you come back, these are the things we want to talk about. The next time you come back, I want you to tell me what medications you're taking. The next time you come back, I want you to tell me what goals you have for the next, and giving them those little intermittent assignments to make sure that they're starting to recognize that autonomy that they need to take. You're going to assess that at each one. You're going to start working on that official transition planning as they get to 18. And then in that 18 to 21 range is the time where, if you have the ability, that's when they're kind of flanking both sides. You're working on that transition, making sure that you're kind of tidying everything up and then getting them moved over. And then at that age, depending on whatever your transition point may be, at that age, that full transition occurs. So how do you think about gauging transition readiness? I will ask, who in here uses the track form? So we have like 3 hands. Who in here has no idea what a track form is? Lots of people. So the transition readiness assessment questionnaire. This is actually one of the main resources when you're thinking about how to transition patients. And this is very much a patient-driven approach. There's a 29 item and then there's a 20 item track form, and it goes over 5 domains within their healthcare. So that's, how do they manage medications? Are they good at keeping their own appointments? How are they tracking their own healthcare issues? Are they talking with providers on their own? And what are they doing as far as their daily activities? So again, this is looking kind of, you know, you've got your 29 item track, which is way more detailed than your 20 item. And you can use either one of these, but depending on kind of the developmental age, you know, a spastic quadriplegic child with CP who's not doing any of this, it's just a matter of kind of going over this with their parents and understanding that patients with spina bifida or patients with hydrocephalus that are intending to become independent, you want to kind of push them a little bit further on this. But it's simple stuff. It's, do you fill your own prescription if you need to? Do you remember to get your refills? Do you know what to do if you have a reaction to your medication? Do you take them on your own, and do you take them correctly at the normal doses and times that you're supposed to? And do you request refills in a timely fashion, or do you request refills a week after you've been out? And then if they have equipment, so, you know, in our spina bifida population, you know, who's helping with your equipment? If you need a wheelchair adjustment, do you know who to call? Do you know where to go? Those types of things. With appointment keeping, it's, you call your doctor's office on your own to make an appointment. Do you follow up on referrals? If you're referred somewhere, are you making those appointments on your own, or are you waiting until you get that phone call? For our patients that need ride shares or figuring out transportation? Do you arrange that on your own? Do you call the doctor when there's a problem? It's the simple stuff. Are you maintaining your own health insurance? Are you remembering to renew that? Do you actually know what's covered by your health insurance? I don't know that any of us know what's covered by our health insurance, so I feel that personally is a very unfair question. And then, how are they doing it? Are they starting to take on those other parts of their lifestyle, managing their budget and expenses? Now, this track, you see, you're like, why are we asking a 14-year-old if they're managing a budget? I mean, you're going to rephrase that, like, do you have an allowance? do you save? But also the intent of this is that this is something that's going to happen at every single visit so that you can track their progress in each of these skills. So as far as health issues, who's filling out the paperwork before an appointment? Is the child starting to fill it out? Is the family filling it out? Who's filling out the review of system? Is it just mom checking all the boxes where you get the review of system? You're like, really? Everything? or are they actually doing it with the child? And how much ownership does the child have? The list of questions. I love nothing more than when mom has the list and said, this is what, when we were talking about surgery, these are the questions that they had, and they just wrote them down, because that to me tells me that that child wants to be a part of their own care. And then, are they getting any financial help with school or work? Talking with our providers, like, is the child just sitting there letting mom and dad answer all of the questions? Are they answering questions on their own? Do they ask questions? Do they express their concerns? And then finally, daily activities what are they doing as far as meal prep? Do they clean their room? That's probably not the one to ask parents, because I think everybody will universally say no. Are they going to the grocery store? Do they, if they're working or in school a little bit further along, are they requesting the accommodations that they need? Are they advocating for themselves in those types of realms? Are they working? Have they applied for the job? Are they looking at vocational opportunities? So what we're doing is we're going to do this at every single one of those visits, again, starting at age 14 on. And that helps them to understand where their gaps are in taking care of their own life. Focusing on, okay, well, last time your track score was, 6, this time it's 10. We see that you're making progress in these areas. This is what we're going to continue to do. Because it's about tracking as well as goal setting and understanding what you can do to help prepare them for next. So when we talk about spina bifida transition specifically, so this was again looking at, this was in 2019. Again, just talking about how bad we are at this. 81% of pediatrics centers across the country with neurosurgeons had a multidisciplinary spina bifida clinic. Only half of those centers actually had any sort of transition program. Again, we know what we're supposed to do, and it turns out we're just not doing it, or we're not doing it well. And these are patients that are going to have ongoing needs. This is anything from shunt malfunctions to mobility and wheelchair adaptations. You think about driving and making sure that once they're getting independent, are they, cognitively okay to drive? And if so, like, have you worked on getting them into programs that teach them how to use hand controls? They may have ongoing needs with regarding their tethered cord. If they have worsening of function, they're going to have very lifelong needs in urology. Thinking about, have they had any type of augmented procedures that are making catheterization easy? Again, this is a patient population that's at high risk because of their immobility of being overweight, which just continues to add to the other complications that they'll have. How is their bowel function? What about sex and childbearing? I have not had this type of conversation. I am poorly equipped to have this conversation with these patients. Usually I defer to my urology colleagues. Feel like that's a little more in their realm. But this is an issue. They want to know, like, how does this work for me? Am I going to feel anything? Am I not going to feel anything? Can I have sex? How many people in this room would feel very comfortable answering these types of questions? Oh, good. I'm not alone. Right? So these are all of the questions that they have. And then the questions, well, if I can get pregnant, what's my risk? So that what's my risk of having a child with spina bifida? So all of these types of things fall into that domain of what happens next. So some of that is teaching them their own advocacy. You know, I feel like most of our kids that are developmentally appropriate, they can tell me when they're coming into the hospital, unless they're completely attended, this is my shunt. This is what happens when my shunt fails. So knowing that, but making sure that they're abreast of those subtleties, the early signs of tethered cord, having more pain, having worsening function, starting to have more urinary tract infections, making sure that they're aware of their brainstem dysfunction. I have some patients will only present with a change in their nystagmus when they get more symptomatic, either from a shunt malfunction or tethered cord. They have, you know, they're going to have ongoing issues with urinary tract infections. If they don't have normal sensation, making sure that they're aware of what those symptoms are so that they can raise a concern. They're going to have problems with their bowels, and they're going to have problems with wound management. Many of them will have pressure sores just because of the lack of sensation and relative immobility. So the Children's Hospital of Alabama, arguably, I still think they have probably one of the best transition programs in the country. They are a pediatric hospital that is very well aligned with their adult colleagues, but they also have a very, very robust multidisciplinary clinic that has focused a lot on making sure they have a nurse coordinator that will help migrate these patients over to the adult side, as well as pediatric neurosurgeons and pediatric specialists that will actually migrate with them. So they have a very different model, in part because of how robust their network is set up, but also because they take a lot of the ownership on themselves. But in doing so, they've really been able to figure out this kind of lifetime care model that for them starts with a prenatal consult. So from the time that they're meeting with these patients for the prenatal diagnosis, they're really prepping them the entire way through. They're making sure that they have, you know, rehab medicine on board, genetics. They have their spina bifida coordinator. I actually was a visiting professor down there, and because of my interest in this, went to their spina bifida clinic, and I have never seen so many humans in a single multidisciplinary clinic as that. They had 3 physiatrists, 4 neurosurgeons. Every specialty in that clinic was about 3 to 4 people deep. And so they really have this like global team-based care. So in the neonatal time, they're in the NICU, they meet all the providers then they start going to the spina bifida clinic, which you can see. This is the spina bifida clinic. And if you can imagine every single one of those people and several physicians in each of those specialties all in this clinic, where they're then going over and talking. They have like a giant whiteboard where they're tracking who's seen what the next plan is. Each one of them will have kind of their protocols of what testing they need done at different times. And all of that is very clearly laid out. And so the patients know what to expect every time they're coming in. At age 14, that's when they start having that transition, and they actually have a transition nurse that will start going in and doing the track form and doing all of the transition planning with them at each one of their visits. And then their final visit to the peds spina bifida clinic is at age 20, at which point they actually have a full adult spina bifida clinic. So for them, they've been able to create this system where the environment doesn't change for the patient. They have the multidisciplinary team as a pediatric patient. They have the multidisciplinary team as an adult patient. I would argue that is an incredibly unique and not likely broadly applicable model for transition of care, but it has shown that it's possible if you have the resources. So in their adult spina bifida clinic, they have urology, neurosurgery, rehab, the coordinator, and support staff, and then they pull in other specialists as they need to. But because they have this coordinator that can help bring in those other specialists, they're able to maintain that focus. They also have pediatric surgeons that are willing to transition over into this adult side. So they actually have part of what they're doing, and part of what their nurse coordinator is doing when they're coming through, is they're bringing through this individualized transition plan. So this is just a very quick form that they fill out. So they will have the goals set by the patients and their families. Like, what are the prioritized goals for the next, between now and the next visit? And this may be, you know, like, I want to understand my symptoms better. I really want to achieve a functional bowel program and social continence. I want to be able to cath myself on my own. And then they'll write out what their current status is, what actions they need for the next, between now and the next visit, and what the target date is. And then they'll send this home with them, and they'll kind of target when that completion date is. And so what this is doing is it's allowing each one of these patients and their families to really individualize that process and bring it through to that next visit and make sure that they're meeting their goals. So it's not a one size fits all. Everything is going to be dependent upon that. So there's other considerations when we think about spina bifida transition. So obviously I'm saying this as a neurosurgeon. I can't handle all of the issues in an adult spina bifida patient. I'm going to need my colleagues, and we need to make sure that that transition is occurring across the board, or we know how that transition occurs across the board. That partnership is really important. That lead physician or lead coordinator is really important. And then also making sure that we think about the developmental age. Is this somebody that's going to be able to fully transition on their own, or are they still going to be very dependent upon their parents, and prepping for that? So there was an update in 2023. This is just looking at transition of patients with spina bifida. So this, again, kind of really starts at that young age, you know, between the age of 0 to 6, you want to set those expectations, set those long-term plans. What is a realistic outcome here? What are we talking about when we meet transition? And usually by that time that we're seeing how these kids are developmentally around age 6, we're getting a little better idea of what their functional capacity is going to be. You want to know, this is when it's really helpful to have some idea of like, what are the resources available in your state, in your county? Are they eligible for any sort of supplemental healthcare support, equipment support, and understanding what's available. Again, this is a very local type of process. You want to look at regular evaluation of social determinants of health. Are they citizens? Are they not citizens? Becoming more important to these days. And then where they're going to be able to get that comprehensive care, if that's possible, or if not, how that's going to look as they transition along. In that age 13 to 18 is when you want to start thinking about what are the actual needs of transition. So thinking about having a designated coordinator, making sure that as they're going through education, that they're getting regular evaluations and IEP changes as they need it. Think about having a neurocognitive assessment. Partnership with our neuropsychologist is critical to understand where they're going to have gaps, where they may need accommodations, how this is going to affect their ability to take on jobs. And then continuing to evaluate all of those social determinants of health. Really important to start thinking about the adult stuff that's going to be relevant, that you don't want this kind of drop off at age 18 where all of a sudden it's like, oh, I didn't do this. So starting to think about when is that transition of care, 18, 19, 20, 21 or later. Who is going to provide care during that transition process? Who do they call? And then what are kind of the long-term, the financial things, the insurance issues? Many of these children will transition from Medicaid to Medicare because they're Medicare eligible because of other chronic health conditions. And then are they going to meet criteria for other resources such as Social Security? Exceptionally important in this time frame is sorting out healthcare proxy or guardianship if you need to. As I learned in the state of Ohio, any guardianship applications that occur after somebody turns 18 is a completely different process where patients and their families have to individually pay for a lawyer to be able to declare the child unable to move this forward. If that happens before they turn 18, it's fine. So what happens if I miss the boat and I don't start having this conversation and I don't make sure that my social workers are helping them? They turn 18 and their family can't afford that lawyer. And then we have no healthcare proxy. So making sure that you're starting to have that conversation and understanding that that's a time process and getting parents started on that early if they need to. You can also think about different states have different laws as far as shared decision making. Some places have sort of more legal protections that allow parents and their adult children to make informed decisions together, which is separate from a true healthcare power of attorney or guardian where the parents have full rights, but it allows shared decision making and cooperative decision making that allows that ability for the patient to say, I still want my mom to be able to help me make these decisions, but I have not given up my right to say what I want. So understanding those types of laws, because that's going to be very state dependent, and understanding kind of what are the implications in an adult hospital if you're providing care in that type of system. So again, we want to make sure that we're providing them the resources that they need to transition smoothly. So creating a medical summary, include all their surgical history. I would do that in a way that doesn't just like photocopy all of the op reports, because I don't like reading somebody else's op reports. And my favorite op report to read is the cord was detethered in standard fashion and closure was obtained. And I have no idea what that means. So making this a valuable bit of information that you can pass along. And then continuing to work on those things in childhood that will help to optimize their independence, you know, looking at how do we get them socially continent when it comes to bowel movements. And then if you can, spend a little bit of time. I think we've all had these patients that they start talking, and then as soon as they say something, mom or dad chimes in. Giving that patient that allowed time to have a little bit of time on their own with you so that they know that they can let you know what's going on outside of their parents. And then again, talking about making sure that they know what signs and symptoms to worry about, making sure that they have a handoff packet. Once they start getting into that 18, you know, making sure I can't be somebody's primary care doctor. That's a 3-year residency that I did not complete. I am not equipped for that. And as much as I love when my families will like call my office for all things, everything, making sure that they understand how critically important it is that they have a medical home and they have somebody that they can call generally, making sure that you have this constant transition and helping them find that adult person. Also, for those people that do need kind of a formal disability assessment, that's much better coming from somebody who has known them for a long time than asking that to be done on the other end when they transition. So really helping with those assessments before they move over. So very quickly, hydrocephalus is a lot easier than spina bifida. Spina bifida is obviously very multidisciplinary. So there was a healthcare transition summit that really looked at this again from the patient experience of transition of patients with shunts. And most of them said there was not enough planning or I had to do it all myself. Shockingly, they had trouble finding an adult neurosurgeon who wanted to take on a patient with a shunt. There wasn't really any sort of warm handoff. There's a lot of anxiety. Many of these children, because of the number of times that they will have had a shunt malfunction and all of the times that they present in crisis, will have a lot of anxiety associated around being in a hospital setting. And then adjusting to the adult healthcare system. Like, wait, what do you mean I have to manage my own care? What do you mean I have to come in? My adult patients, as they transition, I have to prepare them for the idea that they are not going to see a neurosurgeon every year when they feel good. They are going to come in when they feel bad. They are going to end up with the person who is on call that is not always going to be the same person. Like, these are all things that I have to explain to them because that is not what they've been used to. But the vast majority of patients with shunts as an adult are not seeing their neurosurgeon every year, every couple of years for regular check-ins when they're going about their life. So that, change in the frequency of visits really freaks him out. And I was like, I don't know if you notice this, but we just like chat and catch up when you come in to see me. not actually doing a whole lot. And then, health insurance barriers as they transition from being insured under their parents to needing to find their own insurance. So setting those expectations ahead of time, and that's why it's helpful if we understand what our adult colleagues practice so that we can start having those conversations. You're not going to get an MRI every year. You're not going to get a shunt series every year. You're probably not going to be seen every year. Let's review what your shunt failure symptoms are. Your body's probably not going to decide that it's going to fail in a different way. You're going to have the same symptoms that you always have. Let's review all of those. Some of this has to do with either us or our colleagues really advocating for some changes in policies at the adult hospitals. Visiting hours are going to be different. The ability to have a parent stay at the bedside is going to be different. That's where that shared decision-making really comes into play, because some hospitals will have specific carve-outs for their visitor policy if they have an adult or a caretaker that is their primary decision maker. And then what are the resources that you have to deal with anxiety? We don't have adult life. We have child life, but there is no adult life. We would all be happy about that. But what are those resources that they can turn to? There's a lot of stuff by the Hydrocephalus Association that's really helpful in these transition resources. They have an entire section on transitioning from pediatric to adult care that's available for our patients. And then they actually have available on their website, there is a medical summary form. So you don't have to reinvent the wheel. They have everything from here are all of your childhood providers. These are the surgeries that you've had. This is the treatment that you've had. This is the type of valve that you have. This is the setting that it is. This is the type of shunt. This is the reason that you have hydrocephalus. And you can literally just fill out this form, hand it to them, and they can take it on their way with all of the relevant information in an easily digestible 3-page sheet for your adult colleagues. And then this lets you get into a little bit more, especially I think for those of us that have like slit ventricle patients where there are no imaging changes, to be able to put a little more detail that helps our colleagues take these patients on. The Hydro Assist app is like my favorite app of all time. I now have my team get every single one of my patients with a shunt. This app, they download the app. In there, you can track the surgeries that you've had. Your team residents, APPs, can actually help the family. You can take pictures of the scans and it guides you through. Take a picture of the scan where you have the tip of the catheter, take a picture at the third ventricle, take another picture, and it will show, and you can track with each of those. Is this a time of failure? Is this a time of, is this when everything is working fine? You can track shunt setting changes. So they'll know like what type of valve they have, what their shunt is at, and it will keep all of that in their history. The other thing that it also has is there is a map. So if any of your families are like traveling, and we used to say like have a disc and carry a disc with you so somebody can see what your normal baseline scans are. This will have all of that in like a few key images. They also have, there's like a map on there of like, these are the nearest people that will treat hydrocephalus to wherever you are. So this is actually one of my favorite apps, since everybody has a smartphone and they're not going to lose their phone most likely. I will get every single one of my patients set up with this, and it's been a godsend. And part of that is because it's a shared process of like, okay, well, you're going to enter this, and then I'm going to help you take a picture, and you're going to remember this. It's also giving them that autonomy and that knowledge to make sure that they're taking that into their own hands. So that's a lot of information to digest, and I really only touched on 2 pathologies. It's been a really interesting journey because I've sort of been giving this talk as I've been working on my own transition plan and trying to do that. And I will tell you that the one thing that cannot be underestimated, this is a lot of boots on the ground work. Like this is not something that just naturally happens. It's a lot of work. It's a lot of time. It's a lot of preparation. But my patients that I have been able to transition better, their acceptance of moving on to the adult hospital is drastically different and much better. They're kind of understanding, it's less shocking. They're able to say, okay, well, you kind of told me this was going to happen. It wasn't really what I expected or wanted, but you told me. And so it's been really helpful to kind of think about this in a way. I think you are in a very different position than I am, because I have, an adult hospital system that's across an atrium from me. So really thinking about how you can incorporate these types of practices into your own neighborhood and with your surrounding hospital systems is a very different thing. But I will finish. And this was my home for like a year. I remember I interviewed here in the middle of August for fellowship, and it was 120 degrees out. And I felt like I stepped outside of the airport, and I felt like I just walked into an open oven, and everybody was apologizing to me for how hot it was. And I, the Florida girl who did my training in New Jersey, was just like, I'm coming here. So I came here, and literally the only thing that I had planned for my entire adult life was to live somewhere warm where I could have a pool. So naturally I moved to Cleveland. But I am forever indebted. My year here, I think Ruth jokes that I took a leap of faith. I think that they also took a leap of faith on me, bringing me on as the first fellow. It was an invaluable year. I absolutely would not be where I am today or have been able to do any of the things that I've done had it not been for my year here. So thanks for having me back.
See if there are any comments in the chat.
There is one. Let's see, Dr. Bryan.
I'm not able to read that.
Or that's the attendance.
Attendance.
There we go.
Here we go. Lifetime care home makes most sense, especially for special needs patients. Intellectually disabled remain in the care of their patients or in group homes as young adults, includes primary care and care coordination with a team of specialists who are accessible in a timely fashion. Such a team will facilitate inpatient needs in an adult hospital. Yes, I agree. I think that lifetime care model, again, looking at kind of there's a lot of comprehensive care clinics that are kind of being established because we're getting so good at taking care of these kids into adulthood, and the comp care team is really, really helpful at trying to help coordinate that care. I think in a patient who's got kind of a group home setting, you have that natural care coordination that's a little bit easier to facilitate than patients that are kind of at home or are trying to gain their own independence. So, but very much agree.
Krystal, that was a terrific, really terrific, and a very practical and logical journey through something I definitely don't know enough about. Ruth and I definitely talked a lot about, we've all talked a lot about. I want your advice on something. So listening to everything you've said, you look at the Alabama model, and you're right. That is very, I've heard Jeff talk about this for a very long time. Every time I hear him talk about, that's amazing. There's no way I'm ever going to be able to build something like that ever anywhere. Then you quoted the hydrocephalus summit paper. That was written by Mike Williams and Mark Hamilton. And Mike is in Seattle, and Mark is in Calgary. Both of them are adult neurologists who have a very specific interest in adult hydrocephalus. And so Michael, his doors are open to these patients. So that's somewhere in between. It's not like the Alabama, but at least you have willing people who want to see these patients. In our situation, as I've learned in the 8 months that I've been here, we really don't have anyone on the adult side. I'm not even going to say committed, but I'm going to say particularly interested or willing to see the majority of these congenital patients for a variety of reasons. We have a payer barrier, as you know, because we have a variety of different healthcare systems here who not all of them will see Medicaid. And then we also have really a provider barrier where it's really hard to encourage anyone to want to see these patients. What do you do? Where do you go?
So I've actually struggled with that a lot. And I actually have an adult hydrocephalus neurosurgeon in my practice. But the hard part is the reality of adult neurosurgical practice is they don't have the capacity to just take on these patients and see them in clinic all the time. So the model that I've actually transitioned to is I get them all teed up. I have all of the information, all of that information that's essentially on that form. Because I'm not transitioning them to another physician, I just kind of put that into we have Epic. So there's like kind of a section under their shunt where I can put all of the relevant information in there. And what I've sort of worked out is you're going to see me as this transition is occurring, right before you transition. I'm going to get everything up to date. I'm going to get updated imaging. So you have a new baseline. I'll get an updated shunt series. I'll make sure that everything is good. I'll kind of put that all in kind of a summary note. And then I need you to see this person one time to just establish care so that you have a name and a face of somebody to call. Getting my adult colleague to basically take on that like singular one just as the point person so that they have an office to call has been a lot easier than saying, oh, I'm going to just completely hand that off. Because I've also set the expectation that the reality is that you're not likely to need regular shunt care unless you're failing, in which case you're going to get whoever's on call. And I've set that expectation. So for that particular transition, it's very much about setting the expectation with the patients of what to expect, but also having that kind of little bit of partnership that's within the constraints of their practice of, maybe it's just a matter of you talking to some of the adult hospital systems and saying, hey, we have patients that are going to end up in your ER. How can we get you information that's going to help you take care of them when they do? Would you want to see them one time just to establish care so that they have a point person? And understanding what's going to be on the other side for your patients and then being able to relay that back to them.
So one follow-up, and because I think this affects you guys too, right, Angus? It's like, can your adult partner say no? Can your adult partner say we're not interested in seeing this patient, or we're
So no.
That's the issue.
But I think, and again, that's why this is so individualized, because they may be able to say no to seeing them in clinic, but they can't say no when they're in their ER. Right?
Sure.
Like if they're having a malfunction. And so understanding and having that conversation and just being like, there are adult patients, they're going to be coming your way. They are the closest to your hospital. They've been told that your ER is the one to go to. What can I do to help you the first time that you see them? What can I get to you? What can I send your way? Would it be helpful for you to see this patient one time, just to know what they look like when they're healthy, so that when they end up in your ER, not if, when they end up in your ER, you have the information that allows you to take care of them as best as possible. So sometimes it's about that, right? Because you don't have a designated hospital that you can just send everybody to. But I think that you have people that are at least aware enough that they're going to get these patients, whether they want them or not, and trying to take the road of, I just want to get you the information that you need.
Right. Well, thank you very much. We have a little gift to symbolize our appreciation of your lecture. And
Yeah.
Oh, and for all those in the room, the code is up there. If you can't see it, 47866 for those who are getting credit from the CAM system.
You,
Oh,
should we get a department picture?
yeah.